to everybody. I see some familiar faces and some new ones. Welcome to this week's session on the PalliCovid training. And as we've shared in our email, this is a very special program. My name is Smriti. For those of you I haven't met, I'm the Director of Programs at Pallium India, and I consider it a great privilege to be able to have collaborated with this really wonderful group at PalliCovid Kerala, essentially an informal task force that came together to create, I think, one of the finest resource toolkits that we have at this time. And we're also very pleased to be able to bring that resource toolkit to you via this ECHO platform. The PalliCovid group is made up of several experts, and in our last email to you now, we have shared a link which links you to the ebook that has been created, as well as to a series of webinars that were pre-recorded in preparation for this. The methodology that we will use is the flipped classroom methodology, which essentially works best if participants can go through the toolkit in advance, and that way this session becomes a lot more interactive. I realize that many of you have registered with us as late as this afternoon or late last night, and therefore it's not the most effective that you got the toolkit now, but going forward in the days to come, do spend some time on the webinar and on the ebook in advance of coming for these sessions, because that way you will be able to optimize what you learn here. We have a wonderful group of facilitators who are on hand, and over the course of the next few days, you will get to meet all of them. Here with me is my colleague Rajalakshmi, who handles the online virtual training at Pallium India. I'm now just going to invite Dr. Chitra Venkatesh to say a few words. Chitra, are you here?
Yeah, I'm here, Smriti. Yeah, can you hear me?
Yes.
Welcome to everyone. We hope that you will find these resources useful. We hope that, like Smriti said, I request all of you to go through the ebook and the webinars so that while we interact, it becomes easier, because the ECHO sessions will not be dealing with the complete topic, but bringing out significant salient features. So please come prepared, and we look forward to meeting all of you for this whole week. Thank you so much for being here.
Thank you, Chitra. I'd also just like to add that all of you must have received an email in the past half hour, where we have outlined the competencies that we hope to develop through this program. And so if I may just take you through some of those competencies. One is to recognize the impact of the COVID-19 pandemic as part of serious health-related suffering and palliative care. The other competency is to understand the holistic needs of people affected and infected by COVID-19. And I think this is a very important point, because we have been posed this question: what if I'm not actively dealing with COVID-infected patients and their families? What if I'm not on that front line? The fact remains that while a huge percentage of the population is infected, every single one of us is affected by this pandemic. And the topics that we cover in the next few days will touch upon psychosocial issues that affect all of us. It will touch upon loss, grief, and various other skills that would hold us all in good stead, even if we are not directly dealing with COVID-19 patients. The course is also aiming to improve communication skills, effectively communicate with patients, families, and staff in the context of COVID-19. As a group, we recognize the incredible stress that the healthcare community is under at the moment, the vicarious trauma and suffering that healthcare providers themselves are going through. And when we talk about psychosocial issues and psychosocial care, we certainly will be talking about how to look after yourself as healthcare providers, as well as look out for your team. We will explore issues of goal setting and decision making in the context of COVID-19. We will be able to understand and use management algorithms for common physical symptoms. So if you take a look at the ebook, you'll find that one of the wonderful ways in which my colleagues have worked is they have put together algorithms in a very simple sort of style, which really speaks to the urgency that we're all dealing with at the moment. And so they should be able to give you a snapshot of how the processes are to be followed. Understand the essential medicines required for palliative care and the principles of ensuring access. So while we will talk about certain essential medicines and talk about opioids, we realize that some of you may not have the kind of access that we have in Kerala. And in that regard, we are, as a team, also available to help you and assist you with getting hold of that kind of access. Recognize and assess distress and to effectively use management algorithms for psychosocial and spiritual support in the context of COVID-19, like I talked about. And assessment of distress is I think it's a very palliative care skill, and it is something that is holding a lot of our colleagues in good stead that we're hearing about from in the West. Offer end-of-life care in different settings in the context of COVID-19, an absolutely essential topic for us to cover at this time. Explore and understand the impact of isolation, grief, and loss in the context of COVID-19. Again, something that is universal and applicable to everybody. And to identify the factors that enable compassionate care and avoid burnout for healthcare workers in the context of COVID-19. In many ways, palliative care as a discipline and the principles of palliative care are a humanitarian response to a crisis. And many of the things that we learn in our palliative care practice can be quite effectively integrated into whatever settings we're working in at this point in time. And that's irrespective of discipline, irrespective of setup. So I do hope that you find the next few days valuable. And our past participants who've come in from other parts of the country and other parts of the world have certainly mentioned that in their testimonials, and that is mentioned in the brochure. So I do hope that you will also interact with us, use this opportunity to interact with some extremely accomplished and well-versed experts in the field, and make the most of this time together. So thank you very much. And I'm just going to check. Okay, I'm now just going to introduce our facilitator for this session. Many of you are quite familiar with her. Some of you might be meeting her for the first time. Our first facilitator is an important part of the whole process of, we're learning from her on a daily basis, and a lot of the flipped classroom methodology is something that she has a lot of experience with. And Dr. Moira Leng is here with us. Long time, I've been a part of the palliative care community in India for a long time as an educator, friend, practitioner, and mentor to many of us. So we're very delighted to have you here, Moira. And we've just gone through the competencies, and I'm now going to hand the mic over to you to take us through today's session. Thank you, Moira.
Smriti, could you just introduce me a bit to the group, who's here, where they're from, and that kind of thing?
Sure. We have people here from Shillong, from Meghalaya. Negrams is a team here from Negrams. One moment, please. We also have a group from, one moment, there's a bit of a tech issue. We have a group from Uttarakhand as well. We have Sister Stella, not Sister Stella, we have Stella Matthew from Butterfly. And We have colleagues here from Calcutta, Pranab Basu, who's a volunteer, who's been doing a lot of work in the community, has done other programs with us, and a great advocate of palliative care to everybody in the East. There's Dr. Jagriti Kamdar, who's new to palliative care, but also an avid advocate from Bombay. And there are several others here, Moira. I'm afraid I'm not personally acquainted with all of them, but yes, a very mixed and diverse group. And yeah, happy to have everybody here.
Lovely, thank you, and sorry for the delay this side. It's very nice to meet you. Can we just all get comfortable with two things? Can I ask you to find the reaction spot at the bottom right-hand corner? I'll show you just now as if I was doing a tick. Can you see that? So if I can ask you, just because we're wanting this to be very interactive. So find these buttons and work out how to use them. Many of you will know already. I'm sorry if I'm telling you something you know. Thank you, Stella. Thank you, Praveen, Sunita, wonderful. Can I also get you to find the chat box? Introduce yourself on there. If you have done already, you don't have to do it again. I just won't have seen that. And let's start discussing and asking questions. I presume that you've already heard that these sessions are only part of the course. The course is actually something called a resource toolkit, and that resource toolkit has webinars, it has an ebook, it has algorithms. Those algorithms will be the things that we will go over in these sessions, and then it has 5 sessions. So some of you have come in just registering yesterday, so apologies you didn't have that information in advance, but I think it's now been sent through to you. So please let us together learn this week. We want to learn from you. We want your experience, your expertise to be part of the teaching for everyone. And those of us who are experts are expert facilitators this week. For those of you who prefer a more standard lecture, that is there in the webinar. So that is there for you with more of maybe the knowledge background and so on. But we're really wanting this to be as interactive as we possibly can. And I recognize that in this call, even though I don't know all your names, there's a phenomenal amount of expertise already. So I'm really delighted to see comments. We have people from maxillofacial, we have people from dentistry. That's wonderful. Great, delighted to meet you all. I'm going to share now 2 short presentations. One is just to complete the introduction that Smriti very kindly started, and then we'll move on to the main topic, which is decision making. So I'd like you to start already to be thinking of what are the issues around decision making that are a challenge for you right now, that you have something you want to share about or questions you would like to ask. Is that clear? If it's clear, you can give me a tick now that you know all know how to find the tick. Yay, I've seen at least one, I'm happy. Okay, let me share this screen and then we'll take it from here. Okay. So you've already had the introduction, so I won't do that again. Thank you, Smriti. And this is the toolkit that I've just mentioned. All of these information is contained in an email that was sent to you. I want to just touch on these domains that we're looking at this week. Triage, symptom control, management of distress. We're using that term distress to talk about the psychosocial, the spiritual issues. Of course, end-of-life care and support for the healthcare worker. And we're looking at how to support patients who directly are infected by COVID-19 and their families, but also to look at how we support the wider community who are affected, and not least in those issues of distress, mental health and loss, and of course to support each other. We've already covered this, so that's great. We're encouraging you, once you've been part of this training, to use this in whichever way is useful. The algorithms can be printed out for local use. We've got some people who are using this in different languages and liaising with us, for example, colleagues in Bangladesh. So there's different ways we can work with you to help take this forward. And some of you are new to palliative care. We're going to be talking about issues that affect all of us, not specialist issues particularly, although of course you can ask questions relevant to your areas. we're talking about this idea of holistic care that goes alongside disease intervention, whether that's infectious disease intervention, chronic disease intervention, where the emphasis is on quality of life and on supporting the patient and the family and the caregivers into bereavement as well. I just want to just mention that we've been looking at, particularly in Kerala, but in other places internationally, at how palliative care should be involved in pandemics, not knowing, of course, one was just round the corner. So again, these are things you can read about, but there's been some work looking at what happens after an earthquake, what happens in a situation like I've got in Uganda, where we have many refugees coming because of conflict, what happens in floods like we saw in Kerala and in Assam quite recently. And we do have these literatures that give us more information and a WHO guideline that helps us move this forward. We've also got an excellent paper in the Lancet recently, which chooses the same dimensions really that we have chosen: communication goals of care, symptoms, distress, end-of-life care, and so on. And this is an excellent review article. You will have the references in your slides and in the webinar. And lastly, we're delighted to see that WHO, through the World Health Assembly, has actually supported this kind of integration. So welcome, you're part of something which is now being supported very widely as important for our practice as healthcare workers in the context of COVID-19. And who are the vulnerable people? Children. These are children from the Rohingya refugee camps. Those who are enclosed prisoners. We know very well in India about the migrant workers. These are migrant workers trying to return to Nepal. We see some situations, a refugee camp, where people are managing some social distancing, but it's hard. And of course, we remember particularly the elderly in our populations, some of the most vulnerable. And we recognize the many acts of creativity, innovation that are happening all over the country of India and more widely, as people are yes, they're distancing physically, but there's also this, I would say, an outpouring of compassion and empathy. And as healthcare workers, you are right at the heart of that. And so just this introductory slides, I finish with this quote. It comes from a letter we wrote in the Lancet, which reminds us that what we're particularly wanting to bring to the table is these issues of talking about our mortality, engaging in humanity and what that means in terms of ourselves as healthcare workers and those that we care for, and also looking at how we can do that while we relieve suffering and uphold dignity. So that's the end of my introductions. We're now going to move on to the topic of triage. So I'm wondering if anyone, thank you for all those lovely introductions. Thank you, Pranab, you're working in Kolkata, that's great. I can see some really interesting, and welcome to a colleague from Accra. I've been to Accra and I've been to Corlebu. I don't know if we met, but it's, yes, absolutely. I remember you well. I remember you well. I've just seen your name. Thank you for joining with us. That's fantastic. And we've got people working in remote settings and people in the main hospital there in Delhi and AIMS. Fabulous. So when I mention triage and decision making, what are the sorts of things that come into your mind? This is in the context of COVID-19. You guys are on the front lines. What are the things that are challenging for you as we begin to think about triage and decision making in the context of COVID-19? Just pop them into the chat if something comes to mind. So we're going to, I've got the chat. We're going to touch on various principles, but we're also going to anchor all of our learning this week around a case that we've designed to illustrate some of the problems. But I would love it if our case is balanced by your own experiences and your own sharing. So please don't lose that chat button and keep sharing with me. There are extra learning objectives covered on the webinar, but we're going to particularly look at how we balance the ethical decisions in a clinical scenario and look at the algorithm that we've written to try and support us in our practice. reflecting always on our values. Just a reminder again, if you haven't downloaded the book, please do so, and remember about the other resources so that we can really be interactive sessions. So as we think about ethical principles, I wonder what comes into your mind. Some of you are going to go back to your medical school or clinical school days and think what those 4 main principles are. But as we think of the theory, let us remember that they are simply aids to help us make appropriate decisions without relying on what I call situational ethics. So it's not that the situation suddenly forces into a series of decisions, but rather that we think through some of those ethical decisions and then we apply them, those principles, into what can be a very difficult series of decisions, particularly around situations such as COVID-19. Remember, these are not legal frameworks. You may have legal frameworks. India has some clear frameworks. Ghana, you will have. Uganda does have. They should ideally reflect good ethical practice. We know that they don't always, but they should do that. And you must remember to look at your own setting, institutions, and take on board AIMS, for example, in Delhi has a very good end-of-life care ethical policy, for example. So this balancing act, what are the principles? How do we apply them? How do we look at the best needs of that patient and their wishes and their family and balance that against the resources? Particularly the tough resources. You know, we've heard today that Delhi is commissioning trains to put COVID-19 to isolate them. These are difficult times, and this can feel like a balancing act, which is a bit impossible. But I'd like us to, by the end of this session, feel at least together we have some empathy for one another as we make these decisions and have some basis on which we will decide. Not that it's a maze we can't find our way through, but that we have some clear signposts along the way to help us. And I just mentioned again that there are particular issues for us because of the vulnerability of patients, the rapid progression of this illness, the complexities of the political and the social environment that we find ourselves, the fact that holistic issues are often ignored with the emphasis on disease management, and yet, of course, the societal and the holistic issues are impacting hugely on disease management. We have stigma, we have fear, we talk about suspects, even the masks and so on, while they may be of sensible public health benefits, they're distancing us. And we're really under pressure as healthcare workers. Some of you on this call may be under a lot of pressure, and I hope this week you can share some of those feelings with us. Okay, I don't think we have yet any particular issues that come into your mind when we think about triage. So let me instead look at this scenario. So I'm hoping you'll look at it with me. Here we go. So we have a patient called Ramesh we're going to follow through this week. He's an elderly gentleman. He has a number of comorbidities. And of course, you know that many of these comorbidities are significant in this context. He's housebound and needs help with most daily tasks after his stroke 6 months ago. His wife is there, his daughter-in-law and sons. So look at this scenario, and I don't think it will be totally unfamiliar for many of you, either from your family context or from your work context. What do you think are the issues that we need to look at if we're going to make decisions? Pranab, thank you. You're talking to us, that's very important, about how you're missing a whole area of communication. That normally we would use all of our non-verbal skills and also some of those physical touch skills, and yet we're not able to do that. So we're going to have to think of how we deal with issues in this context where communication is more challenging. Any other suggestion about what are the issues in this scenario? Maybe the family are saying to you, what should we do? We've heard that there's going to be this COVID-19 is here. What are the issues for this patient in relation to COVID-19? Any suggestions? Goals of care. Thank you. So we need to work out what is his goals of care. That's a fantastic answer. Thank you. Any other suggestions? You're just warming up at the start of the session, I know. How would we ascertain his goals of care? We do have that chitra, but I want us to look at the goals of care just now as well. Yeah. How would we ascertain his goals of care? Any suggestions? Because that is the crucial part of ethical decision making, is we need to ascertain the person's goals of care, maybe help them adjust those goals of care while we take into account the overall situation. Let's move the scenario on a little bit and see what you think. Can I ask you, first of all, if this gentleman was to be infected with COVID-19, what is the likely outcome for him? What is the likely outcome for him? You're absolutely right. The patient may not be able to visit hospitals. We've seen in some settings very good organisation of hospital care. We've seen in other settings this distressing sign of patients going from hospital to hospital with their carers trying to get help. He's very high risk. Thank you, Shankar. Sunita, you're right. In some settings, this patient can be managed at home. Clearly, each setting we're in is going to be different, but most of low and middle income settings are asking that patients be admitted, even if they're not going to have invasive treatment. And that in itself is a challenge, is it not? He has multiple comorbidities, absolutely right. So there's the issue of how we advise and support this patient before they get COVID-19, so that we can be starting having some of these goals of care discussions, some of the conversation around what's been called shielding in the UK, so particularly protecting the elderly and the vulnerable. He's got daughters-in-laws and sons, some discussion around how they should manage that scenario so that he has least chance of getting COVID-19 and the family also are protected. Because we know that recovery for those who have comorbidities, who are elderly, is really quite poor. There's a number of studies coming out. There's even more since this study. But there's a concern that we are writing off our elders. What do you think about that? Are we writing off people if we don't give them mechanical ventilation when they develop respiratory symptoms? I agree again that they may get panic for sure. So just in principle, what do you think? If we don't ventilate somebody like Ramesh, are we writing them off? What do you think? You can actually just put a tick or if you think we're writing them off, you put a tick on there and see. Shankar, you don't think so. I'm not seeing many ticks. But this is a question we're going to be asked, is it not? This is a question that the families are going to think. They're going to feel the reason we're not treating them is because there's not enough money, because we don't care about them, because they're elderly, because they belong to a disadvantaged group. Not so? So we need to find a way to take these graphs and explain them in a way that makes sense to our patients. To say that actually not doing something can be the ethical thing to do. Now, we wouldn't maybe use those words with patients, but we need to internalize that ourselves, because futility and quality of life are important. We don't do things that are not going to be of benefit, but we do things that are going to help. You know those principles: beneficence, non-maleficence. We take account of the patient's needs, autonomy, but we apply those with our medical understanding, and then we communicate in order to discuss goals of care. So thank you, Rajashree. You're saying the focus should be on providing comfort care. So Anupama, you're asking something important. Would they want ventilation? So let me ask you again, if they would like ventilation, should we do it? That is an autonomy decision. So if somebody would like ventilation, should we do it? What do you think? And remember, this is an environment where it's not about right and wrong. It's about sharing and understanding, because these questions 100% are coming up. So a couple of you have said no, yes, okay. So that's interesting, isn't it? So even amongst ourselves, we have some differences. Excuse me. I'm seeing that we ourselves are in that position where it's difficult. Maybe we're in a private hospital where the normal thing is that you do ventilation. Let's look a bit at the model we have here, and then I'm going to go on to a goals of care scenario. Thank you. You're talking to me about, yes, I like this. You're saying we may not even have it, even if we want to give it. And that's very true in many settings. And some of you are saying it depends on the scenario that they're going through and the health condition. So in Kerala, there's been quite a clear plan set up that's involved community surveillance, telephone help, field response, and then treatment centres at various levels. Kerala has had the advantage of, if you like, trialling its response and working out a really good system of how to operate with previous episodes such as the Nipah virus epidemic. But even the most planned health system can struggle, never mind one which is not so planned. So let's just go through what is a goals of care algorithm that you have and think about how this might help us in those decision makings. So we have confirmed or suspected COVID-19. Our patient Ramesh comes into this side. He's over 60, multi-morbidities. He was already very frail. There are a number of tools we can use, and we'll mention some of those to determine frailty or function. But we can see in whatever tool we use, this is a frail man. So we need to be ready for these conversations. Dr. Chitra is right, there's going to be more talk of communication tomorrow. So how we are prepared, how we check the understanding. Because the first decision on goals of care, the first discussion should be how much does the person understand and what is their feeling at the moment. But it's good to be prepared ourselves in case we have to have these discussions under rather challenging circumstances. We then also have to work out whether the person themselves wants to have this conversation, or at times, maybe because of their frailty or because of their preference, they want to involve somebody else. Don't do that automatically. Try and involve the patient, but of course we do find circumstances where that's not what is required. We do look at the setting. We do understand the background. So we say to families things like, I can see that you want the best for your patient. We also want the best for your patient. We want to make sure that they're not suffering and they get the treatment that's going to benefit them most. So we're starting with that position of together we want the best for your patient. This goals of care document, sorry, that's just gone out of sync, brings out those issues that some of you have already mentioned. Communication. And remember, when we communicate, to document. Yeah. So make sure we communicate and document. Abhijit, thank you for reminding us that these conversations, as I said a little bit before, we can have them in advance. If you're working in situations where you see people with significant comorbidities, or if you're in touch with them, why don't you get some of these thinkings and discussions to happen in advance about quality of life, about safety, about security, but also decision making. Now, we have this challenge, don't we? We have autonomy, but we also have beneficence, non-maleficence. We have the requirement to not do harm and to do good. To ventilate somebody with no prospect or almost no prospect of recovery is actually doing harm under most ethical principle discussions. It's a tricky one. It's a tricky one. Because sometimes we've not made decisions based on those ethical principles, made them based on the situation. So autonomy is hugely important. And we balance autonomy with what we know about the medical futility. So if it is helpful, if someone is elderly with no comorbidities and very fit and well, we may actually decide if they have a severe respiratory distress, the ventilation is a good option, medically speaking. But we may not. And in fact, one of the challenges for us is to have those conversations well. And my colleague from Ghana, in Uganda and Ghana, we don't have so many ventilators. So in some senses, the lowest income settings may have already thought through some of these issues, because every single day they're having discussions about not having malaria treatment, not having basic healthcare, never mind ventilation. Remember at all of these stages to look at symptom control and end-of-life care, which we'll come up on other days. Let me just move on to this. This may look a bit complicated, but this is really an algorithm to help us look at decision making. So we take down the green side, people likely to benefit from any intervention we're suggesting. Remember, there are non-invasive ventilations and more work coming about other treatments. But on the yellow side, we have people for whom we're having to think about, will this benefit? And if the conclusion of the multidisciplinary team, try not make this decision alone, document our multidisciplinary decision, have some backup. Some settings have a triage supervisor that you can go to when there is a conflict, maybe between what medically we feel is appropriate and what maybe the family feel. But remember, talk to the family as an ally. Don't talk to them as someone who is a distant person who is declaring life and death on their patients. We know that's not what we're doing, because we know that actually some interventions are not going to benefit. But unless we get that empathy and unless we get that communication effectively done, and it's an ongoing process, we may leave families feeling that they have to fight for the care for their patient. Remember always to say there's a lot we can do in terms of all the other aspects we're going to talk about this week. When we make those judgments, in this scale, we've suggested, if you using as part of our assessment, if you look up the top here, top right box, using the WHO performance scale, you see that here, because it's quite simple and straightforward to use in any. So use the clinical frailty scale. This has been used in other countries such as the UK, which, sorry, my side, we're having some problems with the video. Yeah, which maybe feels a bit more appropriate for an elderly population. But again, remember, in all of these scales, we take into account people with very poor prognosis and complex multimorbidities. So let's come back to Ramesh. We're scoring him at clinical frailty score 7, excuse me, and WHO score 3. So this is a severely ill person. Very high risk of poor response if they do develop respiratory failure. Shall I tell you a bit more about the background? He's a retired mechanic. His son runs a provision store. You're already beginning to think of the implications for this setting. One other son returned from the Emirates recently. They're on home quarantine. They've got a small house, semi-urban. Neighbors are saying, you're at risk. And he thinks the elderly are not going to be helped and asks the family doctor, what will happen? How are you going to respond when that question comes to you? Any suggestions? Any suggestions how you're going to respond? It's a tricky one. Any of you finding this kind of scenario where people are asking you? And there's some important social issues in here too, aren't there? There's some issues around the home circumstances. There's maybe some good advice we can give there. There's issues around the whole family and how they're going to manage. Lovely, thank you. We're going to reassure him that we'll look after him. Absolutely. I think that's one of the most important things. One of the key ethical principles that have been argued in a global sense is non-abandonment. Let us not make people feel they are rejected, abandoned, not worth treating, not worth caring for. But let us balance those decisions with what we call justice. What are the resources? Who is going to benefit most? That doesn't mean we say everybody over 75 don't get treatment. Not at all. We say we will make treatment decisions based on the individual, their wishes, their circumstances, their health, their family wishes, and in accordance with the resources that we have available, as we do day in, day out in low and middle income settings. Great, thank you for all those lovely comments about listening and concern. Being present, even in a brief moment, even with our PPE, there's ways in which we can demonstrate empathy and compassion and preserve dignity. Hugely important. Someone has brought up the issue of the family state finances. That's part of the circumstances, isn't it? Circumstances. I saw someone in the US was given a $1 million bill for their COVID admission. Fortunately, I think it's going to be overturned. And remember, you're part of a family. This cry from a young Zimbabwean, the first Zimbabwean to die of COVID-19 in ICU, feeling scared. Let us make sure we're dealing with the issues we can definitely deal with. You've got a very good point about the living conditions and whether we could do anything more about that. I'm going to stop the share just now, and I'm going to carry on those discussions. We've just got around 10, 15 minutes more of discussions. So there's the principles, there's the outline. Any more questions we want to do? I particularly want us to raise this question of the economics of the family. Say the family is well off, this family is not. But say they were well off and they said, we don't mind, we'll pay for ventilation anyway. What do you all think? What do you think? How comfortable are you with this issue of justice? And while you're thinking about that, I think the issue of helping people with their quarantine is really, really important. I saw a village in Malawi, a very poor village, but they had a village member who was doing public health training abroad. And they had a discussion with the family elders and with the village, with this public health expert. And they moved the grandchildren into different accommodation from the elderly, but the grandchildren learned how to do the hygiene and how to cook the food and support the elderly. So there's definitely ways in which we can learn, even in the most modest of circumstances, how to keep our elderly colleagues safe. Any other comments from the group? How do you feel when you have to make these sorts of decisions? How do you feel? Do you feel confident? Do you feel concerned? And Dr. Mukherjee, I think you've told us a few times that in your setting, ventilation is the norm. How do you feel you're going to handle situations such as this in your setting? A lot of excellent. Socioeconomics is a factor. It's an interesting one, isn't it? Some people say ethically that's very uncomfortable because everyone has equal value. But we know that everyone has equal value, but they're not all in the same circumstances. So as far as possible, we make the best decision for that person. But we have to also take in mind the circumstances that they find themselves in and that we find ourselves in as healthcare workers. Thank you, Dr. Mukherjee. So you're feeling that we can evaluate him holistically and then decide. So we're deciding the clinical framework based on the evidence, based on some of these tools I've mentioned. We're documenting that, and then we are going to communicate that in a way that is as transparent and helpful as possible. You're talking great. You're talking about care and comfort, non-abandonment, looking at the circumstances. I see sometimes people who induce pain in our families by the financial implications. Do you think we do that? I think sometimes we do that. So making good decisions that are going to be the best for that family at large. I work in internal medicine here in Uganda, and we work very closely with the dialysis unit, for example. And we see that if we don't have these conversations effectively, that people will sell their possessions, take their children out of school, to then only extend their dialysis time by a month or two, and not because we struggle to have those conversations. So, Dr. Kumar, we go for it and improve the quality of life. Do you mean we go for it in terms of ventilation, or we go for it in terms of overall interventions? Since we have still around 5 or 10 minutes, if anybody wants to speak out loud now, you can just raise a hand raise a hand on the do that reaction sign, the clapping hands, and then we can unmute you and you can share with us. Yeah, thank you. So that's a very interesting comment we have there, putting yourself in someone else's shoes. We talk about empathy as being in someone else's shoes. It's sometimes difficult to do that though, isn't it? And sometimes we can put ourselves in the shoes, and yet it's our emotions. So we try and imagine their circumstances, but we do that with our healthcare knowledge and advice to balance that. And we show compassion, whatever. Compassion is to suffer with, to say, we are with you in this journey, we are with you to help you, but it may not be that the same treatment is the right for everyone. Yeah, I think it's really important that if we do make these decisions, we do it with the family. We don't say your relative is not worth ventilating. We say that looking at the balance of your father's condition, we would be doing him more harm than good to go ahead with a mechanical intervention. And what we're concerned about is relieving the suffering of your father, not increasing it. It's tricky, isn't it? Great. I think you're right, having a multidisciplinary input. There's a multidisciplinary group here. Sometimes our social workers may be the most important people to help the family in this scenario. Maybe the home care teams to look at the home circumstances and see how we can manage. Yeah, absolutely. So Chitra's asking another question. If there's not enough ventilators. Now, early in this pandemic, there were colleagues from Italy who put out a statement and they said, we are now overwhelmed and we suggest that no one over 65 should be ventilated. Did you see those statements? And there was a panic in the global world. Was this the right or the wrong thing to do? And I don't know what you think. They said everybody over 65 because we've run out of ventilators, and the senior people who are coming in being ventilated are staying on ventilators for weeks and weeks. So we should just have a cutoff, no one over 65. What do you think? Wrong. Beanie George. Yeah, please. I'm going to unmute you and ask you to, oh, maybe, can you unmute yourself, Pranab? And
Dr. Pranab Asu, can you unmute, sir, from your end? We are not able to.
that's what you think?
Sir, we can't hear you, sir. Sir, can you yes, sir. Can you speak now?
Yeah. Now it is clear?
Yes, it is.
Yeah. I feel that above beyond 65 ages, one should not be pushed into ventilator. If the life is threatened, and with mechanical activities, I don't like. This is my view. Okay. Am I clear? Yes.
Dr. Chitra, Dr. Moira just left. She might be logging in soon. Dr. Chitra, are you there?
Yeah, I'm here. I couldn't really listen to, I mean, I think he said that over 65, he feels that ventilation should not be an option, and people think, I really understand that, sir. I mean, but we cannot make it like a, that's the issue that we are discussing actually, in terms of, like, that's what Moira also mentioned in terms of, how in Italy a decision was taking, especially when there's a shortage of resources also, then the system actually then works towards how you provide resources to people who need it. So that's where your ethical issue of justice comes into play. So we need to have certain guidelines, and that's where probably palliative care also has a bigger role, where if it is integrated within the system and we have the opportunity to communicate and work with the physicians who are taking care of patients, we can actually help in the discussion of goals of care and facilitate the process and help people with issues that who will not benefit from the vendor, because most of the evidence that we have says that people on ventilators have actually a greater risk of mortality. So we can help facilitate a decision which can lead the way to palliative care and comfort care. I'm not saying at home only, but maybe in the wards of the hospital where you can help manage their symptoms and help them have a better dying or a painless dying process. But it is actually a very sensitive issue and a matter of debate, which will probably, we have don't have right answers, but then I think it will come up because what's happening.
Thank you.
Yeah, Moira.
Yeah, thank you. That's brilliant. I asked that controversial question from Italy because I think most people have said that's a bad decision. And I think I see someone saying life and death is not. So what we're looking at is just simply not ventilation versus ventilation. We're also not saying that ventilation saves lives. It's simply a treatment option, and we use treatment options for benefit. If that treatment option has little benefit, we don't use it. If it is possible to have a good benefit, we use it. So therefore, it's about your comorbidities, your functional status, how you're managing in terms of your independent living and your age. So I think everyone is saying, no, don't just take age. And then we add into that our wishes. So that's what we mean about values-based ethical decision-making. Individual and their circumstances and the medical information. So it's that combination that helps us make the right decision. But I was talking to the head of the COVID response in my country here in Uganda, where I am, and they were saying, what a shame that we're all talking about ventilators, and I know I've done that today, when in fact it's a small component of COVID treatment. By the time somebody needs ventilation, then they've already got severe respiratory illness. If we can prevent, if we can manage complications early, if we can handle comorbidities well, because people are not even getting their treatment handled well, and then if we can make decisions in a ethical way with lots of empathy and support, then we stop seeing it simply as I'm going to save a life or not save a life. We just have ventilation as one of the treatment options that we use for the right person. Shankar's we made the point about living wills. That's really quite interesting. Living wills are really a help to goals of care discussion, aren't they? So ideally, any of us who are healthcare workers find out, even if there's a living will, we check it out and we discuss what is the best way forward. Great, I'm seeing some really interesting, comments. Thank you for that. We just have a few minutes left. Any last questions or comments or questions, things you would like to ask or say at this point? Dr. Raji, you've summarized it very nicely. Not age alone, but what is the likely medical outcome? What are the comorbidities? And what are the patients? And balance those together. And actually, I think most of you do this every day. I think you're used to doing it. We're just doing it in a slightly more high-pressured situation. And that's why we're talking this week about how to improve our skills or build on our skills to be able to do that. Any other questions or comments in the last few minutes?
Dr. Hema?
Yeah, actually, I am also handling a COVID hospital and I am an ICU person. So I just wanted to say that it is really not the age. It is the comorbidities and how you manage the patient before he reaches that stage of ventilation. So as somebody said, that ventilator is a very small part. And I personally feel that age should not be the only criteria. It is the total picture of the patient. How bad is the disease? And especially for an acute condition, which may revert. Had it been something which was, as we all, when we work in palliative care, it's the disease per se, which is going to be so bad that you cannot do anything. Because in COVID also, we have very clear DNR guidelines that a patient who is having severe disease, not responding to vasopressors well, not maintaining oxygen well, even on ventilator, if he arrests, we are not supposed to resuscitate. So, I mean, it's a status of disease rather than anything else.
I think that's so helpful, and we wish you well in your work in ICU. And I think you've just emphasized the point that ICUs already have good systems in place, and they have augmented those systems. And again, ventilation is one of the treatment options that we do if we think people can benefit. So thank you for that. So most of us, including the UK, I saw some comments there, the UK went away from an age-related alone to using the frailty score that I mentioned earlier. So the frailty score is much more about function and comorbidities than it is about age alone. So I think that message is coming clearly from many of you. Thank you for those who are working in dentistry and oral cancer. Yeah, you're absolutely right. So you're making these decisions when you think about NG tubes, when you think about feeding gastrostomies, when you're thinking about treatment options if there's a malignancy, you're already making these difficult decisions. And we make them on the individual, the medical circumstances and outcomes, which can of course change. And we make them also in the financial and economic setting. The fears of our patient and family are so important. And sometimes the ways in which family behave are born out of fear. So that communication, that sense of you're not alone, we're going to be supporting you through this is really important. But that can take a toll on us. So later this week, we will be talking a bit more about how we can look after ourselves. We're going to be talking a bit more about how we help the primary team. Chitra, that's a very important point, so that we empower others to do this well. Dr. Hima, you might be empowering others to say, from an ICU point of view, please think of these things to help us make these decisions. And Sunita, I love that comment. We're in this together. I want to thank you for such a brisk discussion. You really have come on board and given us your ideas and suggestions. Faculty members will be helping facilitate the discussions this week, using what you said today and building on it as we go through the week. Please come with those ideas and questions and queries. And we look forward to just together learning more with all of the different expertise that comes in. I'm going to pass back to the hosts now, just in the last, as we just end our session today. They have something.
Thank you, Dr. Moira, for this wonderful session. So thank you, PalliCovid Kerala group, for giving this idea of flipped classroom. We all look forward to have a good learning in coming weeks. So we'll be having this session on all day from today to Friday from 3 to 4:15. I request all to join before 3 o'clock so that we can start our session right away at 3 o'clock. So we have shared a mail which include the entire resource kit, which include the ebooks and webinars. So I request all to go through it before attending tomorrow's session at 3 o'clock. So we are sharing our feedback now. So please do it and then only leave the meeting. Thank you all for joining in.